Good afternoon and welcome to this month's webinar here at the New Hampshire Insurance Department. We're going to be discussing the Women's Health Services Expanded Access Study. I'm joined by some of my colleagues, Michelle Heaton and Lee Curtis will be our presenters. And as always, Commissioner Betancourt, but before I turn it over to him, I just have a couple of quick housekeeping items. This webinar and all of our webinars are available on our YouTube page, and we'll put a link to that in the comments for you. And we're happy to entertain questions. Please type them into the chat window at any time, and at the end, our presenters will address those questions. Having said that, welcome, and here's Commissioner Betancourt for some opening remarks.
Well, thank you very much, Andrew, and good afternoon, everyone. I am pleased to welcome you to today's webinar to discuss the Women's Health Services Expanded Access Study. I want to thank in particular Michelle Heaton and Lee Curtis for their work within the department on this project, as well as the many members of our team and stakeholder community who have contributed to this important work. Last year, as you may recall, the New Hampshire Insurance Department received over a $600,000 federal grant through the United States Department of Health and Human Services, as well as the Centers for Medicare and Medicaid Services. The purpose of that grant was to help us better understand the barriers women are facing in accessing essential health services across New Hampshire, with particular attention to preventative care, maternal health, and compliance with federal market reforms. Our approach from the beginning has been to listen first, gather the facts, and then determine where the department can make a meaningful difference. This work has included stakeholder engagement, analysis of the current women's health landscape, review of the benchmark plan, examination of insurance-related barriers, and consideration of practical next steps. Today's discussion will provide an overview of that work, what we've heard, and where the department believes we can focus our action and where we can take meaningful and appropriate direction. It is important, however, to place the findings of this study in their appropriate and proper context. Insurance coverage is an important part of access to health care. There's no doubt about that. But insurance is not the entire healthcare system. Many of the challenges you will find identified in the report and that we've identified throughout this process, things like provider shortages, the loss of certain services, rural geography, workforce constraints, transportation, and hospital capacity, extend well beyond the department's statutory authority, but it does provide us with an opportunity to work with other state agencies, policymakers, and stakeholders to address those broader challenges, and we will. This is going to be a team effort. Where the department does have authority, we do see several clear opportunities. First, consumers need insurance information that is easier to understand and use. Coverage is only valuable if people can navigate their benefits, understand their cost-sharing obligations, identify participating providers, and know where to turn when problems arise. Second, we must continue improving transparency around provider networks and access. Accurate provider directories, meaningful network oversight, and a clearer understanding of where gaps exist are fundamental to both consumer protection and market accountability. Third, maternal health and maternal mental health deserve sustained attention. Mental health parity has been one of my highest priorities as commissioner, and that commitment naturally extends to ensuring that women can access appropriate behavioral health services during pregnancy, after childbirth, and throughout the broader course of their care. Finally, we should focus on reforms that are practical, measurable, and supported by data. The goal should not simply be more regulation. It should be better, more targeted, effective regulation, one that provides oversight, protects consumers, improves accountability, and addresses actual barriers without creating any unnecessary administrative burdens or unintended affordability challenges. And again, there's that word affordability. That must remain part of every conversation that we have. Access, affordability, competition, and consumer protection are objectives that must be pursued together. Ultimately, this initiative is about building a clearer and more useful roadmap. We want women across New Hampshire to have access to coverage they understand, providers they can reach, and a regulatory system that responds when the market does not operate as it should. So again, I want to thank you for joining us and for your interest in this important work. I look forward to today's discussion and to continuing this effort with the thoughtful engagement of consumers, providers, carriers, policymakers, and community partners across the state. And so with that said, I'm going to turn the program now over to Michelle Heaton.
Thank you. I think Lee is going to take over the first part of the presentation, but just bear with us for a moment while we share our screens.
Yes, thank you, Michelle. Thank you, Commissioner. Again, welcome to our webinar today. We have a quick scan of our agenda. Today, we'll be discussing a recap of the Women's Health Grant, some of the details from the grant. We will talk about the projects that were undertaken under the grant, and we will also discuss the assessment that was done of our essential health benefits benchmark plan, as well as the landscape overview under the women's health piece. We'll also dive into the analysis that was taken for the benchmark plan as part of one of the projects. And finally, we'll discuss some of that important stakeholder engagement and document review. So just a little bit of a description of the grant opportunity. A little over 2 years ago, CMS released the grant entitled Expanding Access to Women's Health Grant. This provided funding to states to help plan and implement consumer protections and market reforms under certain sections of Part A of Title 17 of the Public Health Service Act within the ACA. The goal was to improve and expand access to both reproductive and maternal health coverages and services. And specifically, the funding under the grant was related to Section 2707, the Essential Health Benefits section, and 2713, coverage of preventive health services. By way of background, the Insurance Department has been working on this grant for over 2 years now. We submitted the grant application to CMS at the beginning of August 2024, and our grant application was approved the following month in September 2024 for just under $611,000. There were several procedural steps we needed to take in order to get the work started. First, we had fiscal committee approval to receive the grant funds in November of 24. Following that, the Governor and Council approved receipt of those grant funds in the following month, December 24. We released requests for proposals for both projects 1 and 3 in early 2025, and a bidder was selected the following month in March of 2025. Likewise, we released the request for proposal for project 2, and we'll discuss those projects in a moment, in May of 2025, and a bidder was selected for that project the following month. Those vendor contracts were eventually approved by the Governor and Council in late July 2025, and so we began work the following month in August 25. So we've been working with the contractors for about 11 months now under this work. We, as part of our grant application, submitted 4 projects, and they are listed here. Our goal was initially to carry out 4 projects, and we'll talk about what happened with the 4th project in a moment. The first project was to conduct a study and produce a report of the status of access to women's health services in New Hampshire. This would include existing impediments to access and ways to improve access. The second project was to develop tools to improve our regulatory oversight of health insurers as it relates to coverage for women's health services. Project 3 dealt with assessing our current EHB benchmark plan, and that was with particular attention for coverage for women's health services and the potential cost of broadening required coverage for women's health services. And finally, our plan was to conduct an outreach and education campaign based on information gleaned in projects 1 and 3 in support of improving access to women's health services. We were ultimately unable to proceed with contracting for project 4 due to time constraints, and those were based on some of those dates that I discussed in the previous slide. Project 1 and Project 3 were carried out by one vendor, Wakely and HMA. They are a subsidiary of Wakely, HMA being Health Management Associates. And this slide will outline what those two projects entailed. So Project 1, a little more detail around that, was to conduct a study on access to women's health services, identify barriers to service, and for our contractor to recommend strategies to the NHID to improve access. These recommendations might include health insurance regulatory changes, as well as public and outreach and education opportunities around available coverage resources. Wakely and HMA also undertook the review and assessment of our essential health benefits benchmark plan, specifically related to women's health coverage. This included evaluating the cost and the feasibility of potentially updating this benchmark plan and required coverage based on access issues identified in Project 1. It also would have included and did include actuarial analysis related to whether we sought federal approval for the EHB changes. And a secondary goal of Project 3 was to protect New Hampshire from federal defrail costs. And now I'll turn it over to my colleague, Michelle, to discuss some of the benchmark analysis that was done under that.
Thanks, Lee. So one of the important things we were trying to do with this grant was we wanted to first assess our New Hampshire benchmark plan to see how it compared with other New England states with respect to women's health services. We also then wanted to explore the potential of updating our benchmark plan. So based on the work that was done, we're able to verify that New Hampshire's benchmark plan is actually comparable or richer than many of the other plans available in New England, with the exception of fertility treatment. Some states do include that in their in some of the plans, and that is not a covered benefit for our EHB markets. That's the individual and small group on exchange markets. But it was encouraging to find out that our core, if you take the fertility out, we have comparable or richer plans than some of our neighbors. So the other aspect of this was to look at the potential for updating our benchmark plan. And under federal rules, there is a specific analysis that needs to be done that looks at plans and their actuarial value of the plans that are available in the market. And there's a list of different plans that you look at and certain tests you run. Unfortunately, as this work was underway, those requirements changed and are still in flux, making it not feasible for us to continue evaluating the feasibility of updating our benchmark plan, because it's just not feasible at this time given the uncertainty of the requirements. And CMS has actually paused for the time being any benchmark plan updates. However, we did get some good actuarial analysis out of the project to price out some benefits and where there could be potentially opportunities to expand access in the future. But a lot of that work would depend on how those federal requirements change for updating benchmark plans. Next slide, please. So the other aspect of that first project was, other than looking at the benchmark plan, was to conduct that study on the access to women's health. So what HMA did is they met with stakeholders to get a sense of the current landscape of women's health in New Hampshire. They held key informant interviews, they led focus groups across the state, and conducted an online survey to gather information and feedback from consumers in New Hampshire. They also reviewed a sampling of plan documents and policies that are currently in place in New Hampshire to assess compliance with laws relating to women's health. So based on that outreach, they learned a lot, and all of their findings are summarized in a report that is now posted on our website. But we kind of put together this chart to hone in on some of the key issues that were identified. And so three of the big kind of major areas of concern that we can kind of lump together are provider shortages and network limitations, affordability and out-of-pocket costs, and low understanding of insurance coverage. And so in this chart, we just kind of wanted to outline what requirements we currently do have in place, what some limitations are with respect to our authority, and where we found some opportunities. So with respect to provider shortages and network limitations, the New Hampshire Insurance Department currently has a very robust framework for evaluating network adequacy. And our network adequacy requirements are actually more robust and stringent than the federal requirements and most states in the country. This is something we are actively doing on a rolling basis, and it is something that we take very seriously. We're also in the process right now. I believe we are imminently entering rulemaking. I think it's supposed to be in our next register, an update to our network adequacy rules. And so the way we go about looking at network limitations is we have standards for time and distance, appointment wait times, requirements for provider directories, and consumer protections in place to ensure that everyone in the health insurance market has access to necessary services. And so we are constantly enforcing those requirements. However, there are some limitations in what we can do in this space. To the extent that there are provider shortages, our regulations are not going to be able to produce providers where they don't exist. Another barrier is just the geography of New Hampshire. We're a somewhat rural state, and we have a mountain range that goes right through it with a lot of lakes. So it makes just the geography of our state difficult to come up with set standards that can be applied to everyone in this state. And so that is one of the limitations, that if people live in rural areas, there are just not the infrastructure there to ensure that they have the same type of access to health services as citizens that are in more urban areas. However, there are still opportunities to do some more work in this space. And so what we have been committed to doing and what we're going to continue to do is improve our transparency about networks and providers. And this goes hand in hand with educating consumers. A lot of consumers just don't really understand how networks work, what it means, what they need to do in order to access care in their network. And we hear anecdotally that there can be shortages of certain types of providers. And so what we're aiming to do with a lot of our transparency efforts that we have in the works is to really highlight where we're actually seeing provider shortages, what types of providers are have shortages, and in what areas of the state they are. And we think that's going to be really important to help out stakeholders and consumers understand, where there are limitations in the state. So the next area is affordability and out-of-pocket cost. We currently undertake vigorous form and rate review to ensure compliance with laws. And so part of what we do at the New Hampshire Insurance Department as we are reviewing major medical insurance plans is we do rate review to ensure that the premium rates being charged are appropriate to the benefits being offered and they're not excessive. Under the Affordable Care Act as well, there are limits on out-of-pocket costs and actuarial value of plans, and different metal levels have different actuarial values. So there are currently regulations in place that help ensure that premium is appropriate and that there are caps on the exposure that consumers have. However, that does not necessarily make products affordable. And we recognize that. There isn't much we can do in the form of regulation to control the overall price of healthcare. But what we can do, again, is improve our transparency and educate consumers and stakeholders. So as many of you may know, some of you may not, we do have an annual hearing every year on cost drivers. We are also we've been introducing a spring forum and this year was our first one, about total health cost expenditures. And so that work of our data team is constantly trying to improve transparency on what healthcare actually costs in New Hampshire, how are our markets doing, where are the shifts, all of that good information. We also have Health Costs, which is a website that consumers can go to, and they can look up a number of different services, and they can see what those services cost in New Hampshire. And we are constantly working to improve that website and our outreach and all our transparency efforts to make sure they're meeting the needs of consumers and other stakeholders. But we recognize that there are still opportunities to educate consumers about how to use their benefits. What does an out-of-pocket cost mean? What's a deductible? What's a cost sharing? Having some knowledge about how insurance plans work and what these terms mean is really important, not only when buying insurance to understand what your financial exposure is, but also with respect to using your benefits. There's a lot of regulations that have been coming in recently that make this information a lot more accessible to consumers. And so we're hoping to step up our education so that we can show consumers how to access this important information. So if they're looking to have some kind of service or they need some kind of treatment, they know where to go to find out how much that's going to cost them under their plan. We've also found that there's just a really low understanding of insurance coverage. And this is something we've always recognized. It's in our tagline, insurance is complex, we're here to help. There are a significant amount of disclosures and important information in healthcare policies and our health insurance policies. Part of what we do as the insurance department is make sure those policies include all of that important information and that it's correct and complies with the law. That being said, an insurance contract is lengthy. It can be difficult to get through, and for the most part, most people don't actually read their policies. And so what we're trying to do in the coming months is we want to get out there and educate consumers about how health insurance works. What are some of the key consumer protections they should be aware of? How should they be using their policy to access the care that they need? And where to reach out if they're having problems accessing that. We've also, as part of the study, have our vendor did point out that there's potential, even though the documents they reviewed met all of the legal standards, there is still some room for improvement in some of that language to improve clarity so that consumers can better understand what some of that language is actually telling them. And so we are going to continue to look at ways we can improve document clarity. So as HMA was talking to a lot of our consumers and stakeholders, they also heard of concerns about things that we would say are outside our regulatory authority. And so some of those issues relate to hospital closures, provider shortages, rural broadband issues, Medicaid policy design, workforce pipeline, culturally aligned care, and expanding mandated benefits. While these are all important information, these types of topics fall outside of our regulatory authority and what we would be able to do anything to address. And so while they're worth noting, we're not going to focus on them because we don't have the regulatory authority. So the other aspect of what HMA did, and I had touched on this already, was that they did pull a sampling of health insurance policies from both our individual and small group market and did an extra review. As I may have mentioned before, part of what we do in the department is review all of those documents before they can be sold in New Hampshire. But just as a double check, it was a good exercise for them to also review those and make sure that they didn't find something that we had missed, and see if there was any room for improvement. And again, they didn't find any issues of non-compliance. All of the documents do comply with the legal requirements. However, I think there's always room to improve clarity, make things a little bit easier for consumers to understand, maybe standardize certain types of languages so it's consistent and it's not confusing for consumers. And so we're going to look at where there may be opportunities to either come up with consumer documents that better explain some of these issues, or potentially through rulemaking mandate a specific way of describing something, but oftentimes that's a little bit difficult to do. So we are looking into our options, and we'll look to see where we can improve the consumer awareness. Next slide, please. So based on these projects, our big takeaways are we are going to be looking to increase our consumer outreach. We're going to create more consumer-friendly resources about specific healthcare issues, such as prior authorization, and some other key issues that often come up for consumers. We're also looking to conduct informational sessions with stakeholders and consumers throughout the state to educate consumers about health insurance and a lot of these key issues. We actually have our first session scheduled next week, next Thursday, up in Berlin. So Lee and I will be going up there to hold our first educational session. But if anyone would like us to come and speak to a group that you have, please reach out to either me or Lee or Andrew or AJ, our communications team, and we would be happy to work with you to set up that presentation. We are also looking to increase our transparency. We're actively working on some transparency efforts to better explain network composition and where providers are located in New Hampshire. So we're hoping to get that information out later this year, hopefully by the end of the summer. We're also going to continue to expand our health cost work. We have the annual hearing every year, but our data analytics team is always looking to revamp and improve upon our health cost website, as well as other resources and information to make sure that the data we have is being conveyed to consumers and stakeholders in a way that is going to help them the most. We're also looking to expand price transparency efforts, and there is some recent legislation that has been signed into law very recently, and we are going to be looking to implement that so that we can increase and expand our capabilities with respect to price transparency. So those are some of the things in particular that we're looking to enhance moving forward. Obviously, we're going to continue to do what we have been doing in reviewing forms and rates as they come in to ensure compliance. We're always looking to strengthen, our regulatory oversight. And so what we didn't really talk about today, and because a lot of that work isn't really public facing, is one of the other projects that we had that is still ongoing was Project 2. We have engaged a vendor who is helping us strengthen our regulatory resources to ensure that we are in the best position to ensure we have the ability to enforce our laws and the resources. So that project is still ongoing, and it's going to go a long way to help our staff do their jobs better. So I think that wraps up our presentation, but we're happy to take any questions.
I'm not currently seeing any questions, but what we'll do is we'll offer another opportunity for folks who have them to enter them into the chat box. We'll pass it off to Commissioner Betancourt for some final thoughts in the interim, and then circle back to that.
No, just appreciate Michelle and Lee going through the presentation today. While the report obviously at this point is completed, the work for the department is just getting underway. And it's going to be a comprehensive process. Devin Quinn has just, I was shocked. I was shocked, Devin, that you did not have a question much earlier than now. But in any event, the process is getting started here at the department. As you've heard, it's going to be a multi-step process. So long way to go. Going to be a lot of opportunities for us to engage with a broad array of stakeholders. So with that said, let's get to Devin's question.
Okay, well, now they're coming in, so sorry.
That's all right. Michelle, do you
has
want to
a weird
read the question?
background, Devin, so I'm having a a little bit of a hard time reading it, but it says provider shortages, limitation of providers not existing. Is that providers accepting insurance or all providers? Where we're talking about provider shortages, it's a little bit of both, but for the most part, it's where the providers don't exist. So there are limited numbers of providers in certain areas of the state for certain types of services. So for example, providers that provide prenatal care and OBGYN type services up in the northern part of the state, there are a lot less providers available than in some of the more urban areas. So that's one of the examples. Another example is with mental health providers in certain parts of the state. There are just a lot fewer mental health providers. So it's not necessarily that from our aspect, when we're looking at provider networks, we're looking at who has the carrier contracted with to put into their network. But if there are no providers or there's not enough providers for them to actually contract with, then that isn't something that the health insurer can do much about. They're not going to be able to produce more providers. But it is a little bit of both. So if there are a limited number of providers, then it's also kind of balancing, are they able to accept new patients, or are they kind of at capacity? And so those are two kind of different things, and we are trying to analyze a little bit of both of them. And so that is part of what we're working on right now, and part of what we're hoping to get some transparency out on later this year. And then no issues of non-compliance were identified. We know that providers are not being paid timely, and denial for basic things like maternal depression screenings are high. Aren't these issues of non-compliance? Well, with respect to what HMA did in their review, they were looking at the forms and procedures. They were not actually looking at what is actually happening. However, we have not necessarily been able to verify some of those other claims. And this is where the big disclaimer comes up that we're only focusing on the fully insured market. And like what some of the stakeholders brought up in the study, there is a lot of issues that are being brought up with respect to self-funded plans, Medicare, Medicaid, TRICARE, plans that are well outside our jurisdiction. And so the requirements for paying and timely payment and denial of claims vary a lot based on the type of product. And so when we're looking at these issues, we are looking specifically at the fully insured health insurance market that we regulate. But that is not the focus of what they were looking at in that study. They were just looking at the forms. So it wouldn't include payment of claims. Okay. Was actuarial analysis done for adding fertility treatment to EHB like surrounding states? Yes, but with a huge asterisk. They did some initial analysis, but again, the analysis that was done was based off of what would have been required to update our benchmark plan based off of the regulations in place at that time. Those are going to change, and so should we look to add that benefit in the future, we would have to redo all of that analysis. And so there's some ballpark amounts that were thrown out there of what we would expect, but we would have to redo that analysis in the future. We would also likely need, well, I'll just leave it at that for now. So we have a ballpark of what it would cost. It would be expensive, and some of those estimates were in line with some of the previous work we had done about fertility benefits.
Michelle, if I might, before we go on to Heather's question, a couple of things, Devin. First, with regard to provider shortages, I think Michelle explained it well, but I think at this point, the discussion around workforce challenges across New Hampshire is pretty well at least identified or acknowledged, if maybe not entirely understood in terms of being able to bring solutions to the table. I mean, I recall back to my tenure in Governor Sununu's office when we were talking about what we could do to increase workforce in terms of nurses. We have a massive shortage of nurses in New Hampshire. And we brought proposals forward like student loan repayment and a number of other incentives to try to get more nurses into New Hampshire to be part of our workforce. As you might imagine too, another aspect of that challenge is housing. And we're having a very robust conversation within the state at this time around housing. If you're going to have workforce, those people need somewhere to live. So it falls into the category of what I described in my introduction of something that we don't necessarily have regulatory authority over, but it is something that we're going to be working with our sister agencies and with policymakers as they continue their thinking and their work around how we increase workforce throughout the state. The other thing mentioned, and again, I think Michelle mentioned this or addressed this quite well, but yeah, I mean, the types of things, Devin, that you described, it'd certainly be an issue of non-compliance. The rub always becomes, the universe that we live in is that fully insured market and not the self-insured. So that makes life very frustrating for us sometimes. And then to your last point, there's been a lot of talk over the past several years around EHB benchmark plans. The biggest challenge for the states is right now is the federal government can't seem to settle on what it wants its policy to be for the states who want to actually undertake a review of their benchmark plan and potentially make changes to it. So until that settles, it's going to be a bit of an unsettled dynamic out there, which is hard for us to navigate. So we've got a question here from Heather Martin. So Michelle, can you see that?
Yeah, it says no perinatal medication management providers that are taking Medicaid. Very big issue. And other private insurance types. So I'm guessing that we're saying there's a concern that there's a shortage of perinatal medication management providers. I'm not exactly sure what's meant by that because any PCP or any provider that provides prenatal care should be able to manage that medication. So I'm not sure what's meant by that specific provider type. That's not something I've heard of before, but again, we don't have any say over anything with respect to Medicaid. We have not heard of this as an issue with respect to private insurance or health insurance that we regulate. If anyone has particulars about that, please send that information to our consumer services, and we'd be happy to look into it. But that shouldn't be an issue for the markets that we regulate. And so we definitely would want to know more about what's going on there.
Just to add to that, I know Heather's a friend. With regard to Medicaid, the folks over at DHHS, they can probably give you a better sense as to what can be done to try to promote more of those particular providers to take Medicaid. I would assume it has something to do with rates and their ability to cover their costs. That's a perennial conversation, but if that's something in particular that needs to be highlighted because it's, and I take you at your word, you know a lot more about this than I do, but if Medicaid is not adequately paying these providers such that there's a massive shortage of them available to treat consumers, then that's something that should be highlighted for DHHS in their conversations in the future with the legislature around those rates.
Okay, I think the concern is that the OB or primary care doesn't want to own these patients that need perinatal mental health. Okay. Unfortunately, that's one of those things that fall outside of our regulatory authority. That is an issue with providers, and our insurance can't force providers to do something that they don't feel comfortable doing. That being said, that seems like a concern because I'd still want to know more about it. So if anyone has specifics, please feel free to file a complaint with consumer, and we'd be happy to look into it and see where we could possibly refer it for further review.
Heather confirmed that one of the issues is reimbursement rates. So that is a problem. To Michelle's point, That is quite troubling. So do bring that through our consumer division so we can do an investigation there. And Heather, you and I could talk about some of this other stuff too, because I think part of what you might be trying to get at there, and I don't want to try to mind read, but I kind of identify a midwife component to your question, so we could talk about that too.
Yeah. I think we might miss, can we release the analysis publicly? We will look into that, whether we're able to do that. I think there's a big caveat there that it's not an analysis that's going to be very useful to stakeholders moving forward, because it was very specific to a methodology that was required by CMS at the time, and that is not going to be the methodology moving forward. And so it is not the same as doing a mandate study or that type of actuarial analysis, but we can look into it and see what we can release.
Somebody let a troublemaker into the chat here. A Shannon Betancourt has said, a prenatal medication management provider is a healthcare professional who specializes in helping people safely use medications before pregnancy, during pregnancy, and after childbirth, the postpartum period. Their role is to balance the health of the parent with the safety and well-being of the developing baby or breastfeeding infant. So perhaps midwives, as an example, aren't getting the rates they need for Medicaid to make it feasible. And Heather confirms that there's a lot of truth there. So
Okay.
thanks for helping to clarify that for us. All right. Any other questions? Jennifer Fizel, I believe, had her hand up at one point.
Yeah, we encourage questions. If you have any more questions, please type them into the chat window. We'll be happy to answer them. And of course, if we can't get to your question now, or if you have a question you'd like to ask us offline, you can always email us at communications@ins.nh.gov. Jennifer, I see your hand up. Please type your question into the chat box so that we can address it there. Okay, and I've put our email address into the chat window so that folks can make a note of that and get a hold of us after the presentation if they have something they'd like to discuss that we didn't cover.
And just as a reminder, this presentation will be on our social media platforms. We've recorded today's presentation, so it is there for your review later, or if you'd like to pass it along to someone who would find this discussion of interest and importance, but was not able to join us today. It'll be on our YouTube page, and I'm sure it'll be on Facebook and Twitter and all of that good stuff.
Great.
I also just threw in the chat the link to our website. If people have a specific concern they want to bring to our attention, the best way to do that is to file a complaint, and that link will take you to our consumer services website with information about how to file a complaint.
Wonderful.
Commissioner, any final thoughts?
Nope, other than to say, well, we've got a last minute question here. Is the written report public? I might have missed that at the beginning. The report that we're talking about today will be on our website either later today if it is not already.
It is, and I will provide a link to it really quickly if I can find it. If not, we will email all of the attendees afterwards and include a link to it there.
Wonderful. And Jennifer, if the question you had was a little bit too daunting to type, apologies that this is kind of the way we do the questions, but give me a call. Happy to hear what's going on and how we might be able to help. Well, I once again appreciate everybody. Thanks for joining us today, and we look forward to working with you down the road on this important work.